Hello. I'm going to try to explain what I do for work. I'm a nurse, and I worked at the hospital for several years, and I did home health for several years, and I've done nursing home work for a lot of years. I graduated nursing school in 2004. Yeah, 2004. So since 2011. Missouri's Department of Mental Health and our state Medicaid, they got together and looked at our clients with a severe mental illness, and they recognized that those clients have a tendency to die 25 years younger than someone who does not have a severe mental illness. Part of the reason is because they have so much going on with the severe depression or severe anxiety and schizophrenia, and so much going on with their mental health that it's hard to focus on, oh gee, when was the last time I went to the dentist? When was the last time I had my eyes examined? Some of those basic preventative measures, it's hard to focus on those. So, and things like diabetes, being able to understand the education that the doctors provide. It's hard. I mean, I know when I go to my doctor, that little 15-minute window, it's a lot. And I'm a nurse, so I can't imagine somebody who's not even a nurse and, how hard it would be for them, to understand that education in such a brief window. So the state, the Medicaid and Department of Mental Health, they said, well, let's put a medical team of nurses, a physician, and some support staff in our community mental health centers across the state. Missouri is very mental health focused, and so my team and I, we work with caseworkers. So our clients most of them have Medicaid, and they're at a stage where they need a caseworker. So whether it's they help them work on things like budgeting, if they have agoraphobia and they can't leave their home, this caseworker will help them work with that. Help them just on various things. They help them find a home. So the caseworker is there for the behavioral mental health things. Well, that's what they're trained in. They're not trained in the medical stuff, and we're not trained in the behavioral stuff. So our role is, it's a team we have 6 nurses. We're about to get a 7th nurse. And like I said, 2 of us directors and a physician. Our role is a consulting role. So a client will come in one time a year and they meet with the caseworker and a nurse. And we go through the body systems. When was your last eye exam? When was your last dental exam? Do you have any heart problems, lung problems, musculoskeletal problems? Anyway, we run through the whole body systems and we look at their diagnoses. And we say, okay, well, it looks like you have diabetes and you're obese. Well, then we tell the caseworker and talk to the client, and that's what they want to work on for the year. They say, I want to work on learning ways to improve my diabetes. I want to learn how to eat healthier, or I want to learn to exercise more, or I want to learn about my COPD, and I want to learn about taking medication as my doctor prescribed it. Or I want to learn about preventative care. So we then, the nurses as a consulting team, we then give educational materials to the caseworker, who then works on those things with the client throughout the year. So the caseworkers, they meet with that client every week, every other week, whatever the client and caseworker has developed to decide that's how often, the frequency that they need to meet. So we are the ones providing that education to the caseworker, who then works with the client. So my nurses have 200 to 250 clients on their caseload. So we can't meet with those clients every month, but the caseworkers meet with them, like I said, every week, every other week, however they have it set up. So then throughout the month, we may say, this population of our 1,000 clients have a high blood pressure and they have hypertension. So let's send educational materials to the caseworker so that they can go over that with these clients throughout the month. Or these clients have diabetes and have a high hemoglobin A1C. So whatever the population of health, whatever the population of clients we're going to look at that month, they're flagged because our state developed a database and it generates a list for us of who all we should be working with. So we utilize the caseworkers. Our physician, what he does is he reviews the medication list, he reviews their medical diagnoses, he reviews all the things that the client said they're working on, or that all the health diseases. He looks at whether they smoke, and he looks for gaps in their treatment. And then he can also provide the caseworkers with ammunition for how they can help their client, not through just education, but it's things like, this client has diabetes. They should see their primary care physician or an endocrinologist every 6 months. Or this client has this medication and this medication. Those medications should not be given together. So then one of us nurses reach out to their doctors, say, hey, just so you know, this client's on this medication. And the doctor may know, and they may keep them on it. They may say, you know, this client needs that medication in order for them to stay stable. And so that's their decision. But we just work in a consulting role. So that's my program. We also, if somebody goes to the hospital, we have a system in place that lets us know, hey, Terry Least went to this hospital with this diagnosis and she got out yesterday. So the nurses, we have 72 hours and we review their discharge paperwork. We get a copy from the hospital and we look and like, okay, well, they got a wound and they've got taught on dressing changes. They added this medicine and stopped this medicine. So beep, 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 beep. Hey, person, I'm calling to check on you from your hospital stay. It looks like they said you need your dressing change. Do you understand how to do that dressing change? It looks like they started this medication and stopped this medication. Were you able to get that done? So our goal is to prevent them from having to go back to the hospital. Like one of my nurses, she had a client, she was calling and they're a diabetic and they got a brand new insulin pen, never had one before. They didn't send her home with needles. The client didn't know she needed needles because she'd never had an insulin pen. So for 2 days, she was just, psh, psh, and her wherever it was, she was getting wet, and she didn't understand that. Well, that needle should be going into her to provide her insulin. Well, the nurse knew that client, and so she called her, and as the client, like, my blood sugars aren't getting better, something's not right. So my nurse was able to go to that client's home and talk to her, and she had to end up calling the pharmacy, and they said, well, we need an order. So she called their doctor, and they said, well, we didn't prescribe it. So then she called the hospital. Well, she's not here anymore, we can't prescribe it. So, if you're somebody with a severe mental illness, trying to track down who to call and what to call, that's a lot. And so that nurse was able to finally get a hold of somebody who was willing to write a script for those insulin needles. And of course, it was a Friday. So she was able to save that person from having to go back to the hospital and, having to find a babysitter for her kids or somebody to take care of a dog or whatever. So our program, we work in a consulting role and we help, arm the caseworkers with educational materials about what to look for if their client they go in their client's home and they're lethargic and, and they seem spacey. It's not just that they've had too much medication. Maybe their blood sugar's too low. So we as nurses, we know to look for things like that. But somebody who's trained in the behavioral health, they don't know to look for things like that. So my program is really big on teaching. We teach caseworkers, we teach clients, We teach supervisors. We teach a lot of people. So that's what my program is called, or does. It's called Healthcare Home, which is the dumbest name because most people see healthcare home and they think home health. But we don't. We're based out of offices. We go to a client's home to meet with them one time a year, but we're not home health like the traditional home health. And so we usually just say we're population health nurses. It makes it a lot more easy because people see healthcare home and it triggers their brain to home health. So nobody's ever heard of population health nurses, and it's just part of what we do. So we just call it that. So then that way, whenever the application whenever we put out the job description, it doesn't chase people away because they're seeing home health and like, I have done home health. I am not doing home health again. But population health, that's what we do. And so we also reach out to physicians as we look into gaps in their treatment, and we let them know if there's things we see along the way. If a client has a high cholesterol or high blood pressure, we reach out to their doctors and say, hey, we just want to let you know this is what they had at their last office visit. It's up to you how you treat it, but we at least want you aware. So it's an extra set of eyes on our clients with a severe mental illness. Some of our population live in a residential home, but a lot of our population lives in their own home. So that's what I do, and I just thought I'd share that with you all because people ask. So I am the director of a healthcare home program here in my area. Okay, bye. Oh, there is a healthcare home in the state of Missouri. Every county has a healthcare home. So wherever somebody lives in the state of Missouri, if they have Medicaid and they're working with a caseworker, then they can also work with a healthcare home nurse that will work with their caseworker. So it started out years ago. There was a federal grant, and 5 states were proposing what they wanted to do to get part of this grant. And that was in 2011. And then after 2 years, because of improving our clients' health and preventing hospitalization returns and helping our clients with their getting their medications and everything, the actual after paying for the program for all the staff after the state paid, we saved the state, I think it was like $90 million after a few years. So after that grant ran out, Medicaid picked up the program, and so now it's no longer federal funded, it is state funded because we're helping our clients, and it's helping our clients' health enough that it's helping save Medicaid money. So anyway, it's a double benefit, helping Medicaid financially, as well as helping our clients improve their health. So that's what my program does. That's what I do. And just thought I'd share that with y'all because I've had people ask. So, okay, bye.